And that concludes our thematic presentations.
The next item for the day will be oral presentation session number 1, which will be commencing in a few minutes.
Parallel oral presentation session 1A will be held at the Physiology Lecture Theatre, which is this very hall. Parallel oral presentation session 1B will be hosted at the East Lecture Theatre, and parallel oral presentation session 1C will be hosted at the West Lecture Theatre. Have a good day.
Ladies and gentlemen, it is time for the commencement of session 1A oral presentations.
Presiding over this session will be our chairperson and judge, Dr. NILADHARI and Dr. Naika. Mr. Vishwa will be joining us as the timer.
Before we commence this session, we would like to remind the presenters of the following. Each of you will have 7 minutes to present your research. At the end of your time, you will have a Q&A session of 3 minutes. The total time allocated per presenter, therefore, is 10 minutes. And finally, there will be 1 bell ring at the end of 5 minutes and 2 bell rings at the end of 7 minutes.
With that being said, let us warmly welcome our first speaker for this session, Mr. M.R.H.R.R. Hassan, to present their research on a study of chronic wounds and their risk factors among patients attending the OPD and surgical ward, Teaching Hospital PERADENIYA.
Good afternoon, everyone. Honorable guests and my dear colleagues. I'm Hassan from Group 13, and I'm going to present our study on the chronic wounds and their risk factors among patients attending the OPD and surgical ward, Teaching Hospital PERADENIYA. So, what's a chronic wound? A wound failing to acquire skin's anatomical and functional integrity within 4 weeks is called a chronic wound. And the chronic wounds have been a burden since old ages, as you can see, and they will continue to be so. So to classify the chronic wounds, we used our own classification out of the resources from the literature, and we did a pilot study in the Teaching Hospital PERADENIYA as well to find the most prevalent chronic wounds, and we formed this classification, which contains 6 categories, and vascular ulcers again categorized into arterial ulcers and venous ulcers. So the risk factors we were considering were etiological risk factors and constitutional risk factors, diabetes mellitus, varicose veins, deep vein thrombosis, and so on for etiological risk factors, and age, gender, occupation, economical status, and all that for constitutional risk factors. So we considered these facts to justify our research topic. So our general objective was to identify the types of chronic wounds and assess the risk factors among patients attending OPD and surgical wards of Teaching Hospital PERADENIYA during the month of March 2023. And the specific objectives were to identify the commonly presenting chronic wound types and to study the socio-demographic factors of the above study population and to identify the risk factors of chronic wound occurrence and to associate risk factors of chronic wounds to the socio-demographic pattern of the study population. So we used a descriptive cross-sectional study as a study design for our research. So the information was collected from 215 informants during those 2 weeks, and convenient sampling method was the one we used, and data was collected by trained interviewers, our group mates, using a newly formed questionnaire, our own questionnaire, which was translated in all 3 languages, and the data was entered to a Google form at the same time. And we used SPSS version 22 to analyze our data with chi-squad test. So these are the variables we considered. The independent variables have a long list for the completion's sake, but we considered only a limited amount of independent variables, not to complicate our analysis. And there were only 2 dependent variables we considered. They were ulcerative reaction and infection. So these are our results. The diabetic ulcers were the commonest type of wounds we identified, and vascular ulcers being the second commonest, and infected ulcers being the third commonest. And etiologically as well, diabetes was the commonest etiological factor, and infected wounds were the second, and varicose veins were the third. And most of the patients were in between 60 and 80 years. And interestingly, most of the very few patients were above 80 years. And it's the male community which was most affected. And the majority of the patients were from Sinhalese ethnicity, and the married ones were the mostly affected. Most of the patients had an education up to O levels, and most of them had also passed O levels. And interestingly, unemployed ones were the mostly affected group. So the most of the patients were having a monthly income below 20,000 rupees, which was a minimum category we considered. So associations, and finally, interestingly and also surprisingly, there are only 2 significant associations we found. Those were diabetes with age and diabetes with marital status, which means having diabetes, the risk of having diabetes was increasing with age, and the risk of having diabetes was more in married people. And for others, we either found no significant association, or the results were invalid because of the inadequate number of cases we found. So in conclusion, the diabetic ulcers were the most predominant wound type of the study population, while burn wounds were the least predominant wound type, where we didn't find a single case of burn wounds during the allocated period. And identified etiological risk factors were diabetes, varicose veins, deep vein thrombosis, intermittent claudication, prolonged bed rest, malignancy, infections, and skin burns. The commonest etiological risk factor was diabetes, while the infection was the second predominant factor, both in etiologically and also the wound types. And diabetes had a significant association, as I mentioned before, age and marital status, and others no significant associations or invalid results. So for recommendations, we would like to suggest since our sample size is small, a greater sample size, and our variables, the number of variables were so big, so we suggest to minimize the number of variables and deeply dive into the factors and the causations of those chronic wounds, and to minimize selection bias and information bias, different methodologies and different study designs we would recommend, and the time allocated was not adequate, so the time allocation also can be considered, and most importantly, there was not a hard and fast rule to determine the definitive wound type, which means that we had to go with the clinical judgment to find that what this chronic wound was, like diabetic ulcer, like that. So these are our references, and thank you.
Thank you very much, Hassan. And it's a very nice presentation, and you have done some good work, right? So, couple of questions, and the questions you answered at towards the end, some of the questions. Now, this is all about questionnaire-based assessment, right? So, you didn't have a look at the wounds during the data collection, or you just judgmental based on what the patients are?
We actually couldn't have the time or the opportunity to see the wounds because most of the time they were covered and we were not allowed to.
Yeah, so in that regard, now how do you differentiate to make sure that there doesn't overlap? For example, diabetic wound will be infected.
Yes.
So in that regard, in which category of such patients?
So that's why I told that we had to go with the clinical judgment. Mostly, it was like taking a mini history. We had to see all the aspects of the patient, the durations of the illnesses they were suffering from, and so we had to decide the type of wound according to the clinical history they have given. So that's why I told so. We should go with a more solid way of determining the wound type.
So one of your major observations is that diabetes association with marriage.
Yes.
And how do you explain that?
It's actually a spurious result. Globally also that is the same. Actually we couldn't find it in the literature the reason for that. Actually it's a good research gap also to dive into that more deeply.
Oh, maybe the wife is good at cooking.
Yes, I see.
Yeah.
If you check whether the married and unmarried people related to their age, the diabetic increase.
Yes, we did.
Age.
Yes.
Is there any association with that?
No, the results were actually no significant association.
So, what is your clinical implication based on this study? What is your clinical impact within that?
So,
Oils, what else we need to additionally improve our healthcare system?
Identifying diabetes as a commonest risk factor for chronic wound itself is a good thing that we have found because diabetes is a very common disease, a non-communicable disease in the community, and most of the people are not aware about the complications of the diabetes as a disease. So I think that this can be used in preventive programs and educational programs to improve and promote the health of diabetic, preventing diabetic complications, especially foot ulcers, and also getting diabetes as a chronic disease.
One last question from me. Actually, what led you to come up with this research question? Is it your own idea or how this evolved?
Actually, the idea was from all the group mates. Actually, we wanted to do a surgical related topic. So, chronic wounds were a subject that most of the people, most of the researchers have not dived in. Actually, we didn't find a single research done in Sri Lanka regarding the chronic wounds. So, that itself caused us to choose this study to make our research.
Thank you.
Thank you.
Next up, we would like to invite Mr. R.S.D. Alavatha, who will be delivering their presentation on awareness of breast cancer and practices on self-breast examination among undergraduates of Faculty of Medicine, University of PERADENIYA, a cross-sectional study.
Good afternoon, distinguished guests and colleagues. I'm Rusit Alavatha, representing Group 2. Today, the title of our presentation is Awareness of Breast Cancer and Practices on Self-Breast Examination among Undergraduates of Faculty of Medicine, University of PERADENIYA. As members of the healthcare community, we are well aware of cancer and their morbidity and mortality burden on the population. Breast cancer being a very common entity among women, both in Sri Lanka and worldwide, is a major topic of interest. Awareness of risk factors, warning signs, and practicing breast self-examination, BSE, is vital for early detection. Medical students, as future doctors, should be well versed about risk factors and BSE to educate patients effectively, because prevention, treatment, and patient care will be on their hands in the near future. These are our general objectives: to determine the awareness of breast cancer and practices on self-breast examination among students in Faculty of Medicine, University of PERADENIYA. Regarding our specific objectives, to determine the awareness of risk factors of breast cancer, and to determine the awareness of early warning signs of breast cancer among students in Faculty of Medicine, University of PERADENIYA, and to assess the practices on self-breast examination among female students in Faculty of Medicine, University of PERADENIYA. In this cross-sectional study was conducted among 406 female and male undergraduates using a pre-tested questionnaire. Data analysis was done by Jamovi version 2.4.6 and presented using descriptive and inferential statistics. 95% confidential intervals were computed to quantify the association between independent variables, which are mostly related to demographic profile of the participants, such as age and gender, and the dependent variables, which are awareness level of risk factors, early warning signs, and knowledge of breast self-examination techniques. The questionnaire was administered to a group of 20 first-year medical students of Faculty of Medicine and Allied Health Sciences, Rajagata University of Sri Lanka. The findings of this pre-test was utilized to analyze and develop the final version of the questionnaire. Questionnaire consisted of 4 parts, including basic demographic data, knowledge of risk factors and early warning signs of breast cancer, knowledge of BSE technique, and practices of BSE by the female students. In our results show that 29.56% of participants had good awareness of early warning signs and risk factors of breast cancer. 46.55% had good knowledge on BSc technique. Awareness was significantly higher among older, senior, and Tamil participants. Most identified risk factor was first-degree relative with breast cancer, and the most identified early warning sign was breast lump, while internet was the most common source of BSc knowledge. BSc was performed at random by most participants, being at 77%. The main barrier to perform regular BSc is absence of symptoms. There's a significant reduction in participants' ability to recall risk factors or warning signs compared to recognizing the same factors. As you can see, these are the graphical representations of the results we obtained on our study. This graphical representation shows the knowledge of risk factors among our participants. As you can see, first degree relative with history of breast cancer is the most common known risk factor regarding breast cancer at 91.80%, while consumption of less fruits and vegetables was the least known risk factor at 38.10%. And this graph shows the knowledge of early warning signs. As you can see, breast lump is the most known early warning signs at 93.3%, while pain in the breast was the least known early warning sign at 71.9%. Most identified risk factors and early warning signs are the most popular ones. I'm sure if I ask anyone of the audience to name or identify an early warning sign of breast cancer, most of you would say breast lump. Same goes for risk factors. Most of you would say family history or age. Our research shows the same, as these are the risk factors and warning signs more traditional in the sense. But we should have a more expanding knowledge because every detail matters in patient education and prevention. Study shows that 1/6 of breast cancer patients presents with non-lump symptoms. Therefore, it is important to create awareness around unpopular signs. As you can see, this is the source of knowledge our participants had. Most used source of knowledge was internet, while the least used source of knowledge like others such as newspapers, etc. Also, most identified risk factors such as family history, age are non-modifiable. Although it is important to know them for screening processes, it is more important to know modifiable risk factors such as diet, lifestyle and alcohol, although they are not very well recognized as risk factors. These are the ones, as doctors, we can advise patients to modify. This shows the barriers which our participants had performing self-breast examination. Being patients thinking that they don't have any symptom is the most prevalent barrier. In conclusion, this study reveals that only 1/3 of participants have good awareness level of breast cancer, which is suboptimal for medical undergraduates. Nearly half of the participants had good knowledge level on BSE, which is satisfactory. Social media plays a key role in spreading awareness, which can be used in future implementations. Addressing barriers to BSc is essential to promote BSc as a self-screening tool. As our recommendations, medical students should have to be educated more about breast cancer risk factors and early warning signs before they are being exposed to patients. More attention should be given to encourage medical students to retain knowledge rather than improving the ability to recognize. Social media and internet should be widely used to spread awareness about the risk factors, early warning signs of breast cancer, and self-breast examination instead of traditional books. These are the, we have used a lot of references materials for this research, and these are the studies which were done in Sri Lanka as the ones we used as our references. With that, I will conclude our presentation. I would like to take a moment to extend our gratitude to our research supervisor, Professor Padmini Dahanayaka, from Department of Physiology and Department of Community Medicine for guiding us through the project. We also thank our participants who took their time to help our project. Thank you.
Good job, Salawat.
Thank you, sir.
Just a couple of questions and some comments to the a couple of questions now. All these questions are kind of open-ended. None of the questions are open-ended questions. Right? They all focus.
No, sir. We use some questions in the questionnaire. We ask, can you recall any questions or name some risk factors? First, we as a recall basis. First, in the questionnaire, we ask them to name some risk factors, name some early warning signs you think of breast cancer, and after that, we gave them risk factors and early warning signs. Can you recognize these as risk factors or early warning signs?
So, this is a printed questionnaire that you have?
No, sir. Google Forms, sir. We used to Google Forms.
Google?
Yes, sir.
Okay, so they won't revert back and...
No, sir. We make sure that they can't use it. Once they skip to the next page, they can't go back to the first page. And the recall basis was done in the first page, and the recognition was done in the second and future pages. So we make sure that they can't go back to the previous pages, sir.
Right. Now, the sample size is 400 plus, right?
406, sir.
Okay. Now, did you ever consider of analyzing? Now, we have taken both males and females.
Yes.
Right? The impact that the level of knowledge between males and females.
Yes, sir.
Did you analyze that?
No, sir, sorry, we didn't analyze the level.
Yeah, okay. You will see some difference.
Yes, sir.
Suggestion.
Yes,
right?
sir.
Yeah, then again, you say that the medical students should be made aware about the self-breast experiment. As earlier, as part and parcel, during the latter part of training, you would be taught about self-breast experiment.
Yes,
so, because of that, another suggestion from my side is you try to analyze based on the year. First year medical student, second year medical student. I don't know if sample size is adequate for such analysis. Based on that, if you do that, and then you will see another difference. I mean, put everything together, and then it should be masked.
First, we analyzed with badges, and we then put together all the badges results. Yes, sir. Thank you, sir.
How about the awareness of male and female?
Sir, as I mentioned, sir, we didn't analyze the difference of awareness between
number male and female roughly out of 400. It's part of
yes, sir.
because female are more worried about breast cancer.
Yes,
And male, they don't even check.
yes, sir. We gathered the data, sir, but we didn't analyze while regarding to gender.
How this idea came to you, please?
Sir, as we do our surgical appointments, we see patients with breast cancer usually, but most of them we see comes at the end stage. So
whose idea is it?
We all of us, all 5 members of our group, we gathered to think of the idea to do our research, and when we were talking about our interested topics, one of them was this, that we saw most of breast cancer patients coming at the end stage. So if there can be, if we can do a research to prevent or aid preventing that, so that's how we choose this.
What is the clinical importance of this, if you think?
So
Research.
so the thing is, breast cancer diagnosis shouldn't always be a clinical one. So if the patient is educated herself, and patient was asked to do her breast self-examination regularly and avoid risk factors, sometimes they can identify early warning signs, some early warning signs by performing breast self-examination themselves. So if we can educate medical students, the future doctors, to educate patients to how to perform BAC technique properly, and how to identify risk factors and early warning signs properly, we can prevent the prevalence of breast cancer among female students. That's our main purpose of our research. Thank you so much.
Thank you.
Ladies and gentlemen, please welcome our next presenter, Ms. W.M.P. Sandhavini, to present their research on prevalence of chronic pain among adults in a selected GRAMA NILADHARI division in Sri Lanka.
Good afternoon, ladies and gentlemen. I am W.M.P. Sandhavini on behalf of Group 31 of the research carried out about the prevalence of chronic pain among the selected GRAMA NILADHARI division in Sri Lanka. Here we selected APPLICABILITY GRAMA NILADHARI division for our research purpose. Moving on, this is a study. This study investigates about the prevalence of chronic pain among adults in APPLICABILITY, just as I mentioned earlier. In context of chronic pain, according to International Association of Study of Pain, we define chronic pain as a pain that has been lasted more than 3 months of time. And for the pain, we know as medical students and clinical clinicians, the pain is an unpleasant sensory or emotional experience that has been associated with potential or actual tissue damage. And this study was aimed to give a broader insight into a poorly researched area, which is the prevalence of chronic pain, and to identify what common pain sites could be there, and those analyzations could be used for the better benefit of the chronic pain management. And this was a pilot study, and the participants who were selected according to the eligible criteria, eligible inclusion and exclusion criteria. And for the objectives of our research was to measure the prevalence of chronic pain among adults, which is in the APPLICABILITY GRAMA NILADHARI division. We selected APPLICABILITY GRAMA NILADHARI division because of the close vicinity and because of the limited time factor and the resources we had, and to identify the commonest site of the chronic pain and the age group which was mostly affected, and the other objective was to explore the associated factors in chronic pain. And for methodology, this was a descriptive cross-sectional study that was carried among adults. Adults by means it's people who are more than 18 years of age according to WHO guidelines. And just as I mentioned above, before, APPLICABILITY GRAMA NILADHARI division was used for the research purpose, and it was carried as an interviewer-based questionnaire, and the questionnaire was designed by ourselves because there was no such kind of questionnaires has been developed before, because this is a really under-evaluated area, and the sample size was 400. There are 337 adults consented and participated, and 63 people who did not give consent was also calculated, but they were not used in the analyzing purposes. And for the when in the analyzation, since the adult is a broad group, we used to categorize these participants into 3 major age group categories, which is young adults, middle age, and old age. And then the results were taken into a Excel sheet, and then it was analyzed using GraphPad Prism software. And for the result highlights, out of the 337 participants interviewed, only 149 people complained of a pain in any part of the body which lasted more than 3 years, amounting for a chronic pain. And this was an overall prevalence of 44%, irrespective of the age and gender. And as I said earlier, 67 were not used for the calculations. And for the age distribution, there was a significantly higher percentage of females complained of chronic pain compared to males, which is 50% versus 34% of chronic pain prevalence. And this is the graphical representation of that. And this is the the distribution of our participants according to the age groups, and we can see there are a fairly equal number of participants when comparing with the age groups. And of them, 21.9% of young adults and 47% of mature adults and 63.2% of older adults complain of chronic pain. And there was a strong correlation between chronic pain and advancing age, with the highest prevalence of 63.2% in old age groups. And this is the graphical presentation of that. And for the comorbidities, we analyzed about diabetes mellitus, hypertension, ischemic heart disease, and asthma. And there we detected high prevalence of diabetes mellitus and hypertension along with the chronic pain. And this is the analyzation about the commonest site, which is here. The commonest site was the back pain, and it was followed by headache. And this is the whole graphical presentation of the people who complain of a pain, and it has been analyzed according to the age and also according to the site they have been complaining. And as we can see, the commonest site was the back pain. Regarding why can it be a back pain, we came up with some possible reasons and possible suggestions. First one is the complex anatomy for weight bearing and support, and age-related changes and chronic conditions like osteoporosis and osteoarthritis, and lifestyle factors and occupation factors and injuries. And the highest prevalence was in the older adults, and this is also could be due to chronic health conditions, degenerative changes, neurological changes, and so on. And we analyzed associated factors as the comorbidities and the gender. For the comorbidities, diabetes mellitus and hypertension were considered mainly, and the supportive contributing factors could be physical inactivity and sleep disturbances and psychological stresses. For the why female being predominant in prevalence of chronic pain, the contributing factors could be, according to our knowledge, hormonal factors, specific conditions in women and reproductive health-related conditions, and psychological factors. And for the recommendations for future research, since this is a pilot study, for the future research in this area, we should consider more comprehensive study designs with larger sample sizes and a broader area of demographic and socio-economic factors. I would like to thank you everybody, and especially our sir, Professor Kara, and Department of Community Medicine for the immense help they have given us. Thank you.
So, considering male and female, is there a difference is the type of pain, chronic pain, and where it is, and the age?
So, with the advancing age, the prevalence of increase, and
male and female? Is there any difference? No, and the type of pain, the backache is commonest thing. Is there a difference with the male and female? And what is whose idea is this?
Actually, we first consulted and he was preparing us for pain management. And he said, we also have kind of wanted to do something like that. This was a kind of interesting study because we had to go to the internet rather than taking a home and doing it. It was interesting. So, collectively, we are going to focus on it.
Just a couple of questions, but this is about the methodological question. Right? Now, what is the sample size that you came up with?
Sir, the
Yeah.
was 384.
384, right? Okay. Now, of course, I know as a matter of fact, 2 weeks, it's not realistic to get it because now in this case, you have to go from house to house. Is that the approach? Okay, so this is not practical, right? Now, the question is that if you can go back to that slide, you have mentioned that 60 plus number were not consented. So what can you elaborate? What really happened there?
So actually, we were kind of struggling what to do, and so then we talked with Professor and according to the formula, we were supposed to take 384 samples, and adding 10% profile and also. Sir asked us to take, even though we have to take sample size.
So you mean to say that even though the patient did not consent, you collected data? What do you mean?
Like, since we have 400 million, so if they don't give the consent, we just have to calculate for because there's a limitation of the use for 1% from the household. So since there's a limitation, this whole using that sample. In the sample, but it was progressing the calculation.
Alright, so black and white question. So even if they did not consent, you didn't collect data. Only collected data.
We didn't get any consent.
Okay, that's it. Okay, thank you. Good luck.
Thank you.
We missed one last question. You can come here so we can what is the, I know this is a very, very question research area. So what is the clinical implication that by doing this kind of research at the village level or in the community?
Because pain is something that has the pain management that has not been very developed in Sri Lanka. There are pain clinics and pain clinics, but it has not been developed as a kind of developed state. So I believe collectively thought that this could be used for pain management, and also for analyzation. We noticed that there's a high prevalence with the advancing age, and according to the global statistics, we know that with advancing age is going to be a bigger problem in our health setup in our future years. So I thought that we since this is what has been analyzed area, this can be a must take for the analyzation, and if you suggestion can be taken further, if there's results can be used to stay with management.
Thank you very much.
Thank you.
Our next presenter, Mr. DMS Disanayaka, will now present their research on assessing knowledge and awareness of common thyroid disorders among non-medical students in University of PERADENIYA. The floor is yours.
Good afternoon to all.
and Lisa LANKA from Group 5 here to present our research on which is a cross-sectional study on assessing the knowledge and awareness of common thyroid disorders among non-medical students in the University of PERADENIYA. So, first of all, I would like to drag your attention on why we have chosen this topic out of so many researchable problems here. Actually, we are engaging our clinical practices these days and we encounter so many patients with thyroid disorders. And thyroid cancers are the commonest endocrine malignancies worldwide. But despite the increasing prevalence rates in thyroid disorders day by day, we see that these disorders has been one of the most neglected and underdiagnosed medical conditions elsewhere. To our knowledge, we think that is because of the lack of the knowledge and awareness on common among the general public and due to the late presentation towards the healthcare setup due to presenting with very non-specific symptoms. And the reason behind we selecting the non-medical students is that the students who are studying across different faculties represent a very vast demographic and socio-economic background in Sri Lanka. So that's why we have chosen a knowledgeable set of this population and we think that as the future workforce in our Sri Lanka, that they might contribute to certain interventions to improve the public awareness with regard to the thyroid disorders. So with moving on with this background, let's move towards our objectives. So our main objective is to assess the knowledge and awareness of common thyroid disorders among non-medical students in the University of PERADENIYA. And these disorders include hyperthyroidism, hyperthyroidism, and thyroid cancers. And the next objective is to compare the knowledge on common thyroid disorders based on gender, advanced level study curriculum, and previous exposure status to the thyroid disorders either by themselves or by their family members. So now let's see how we have gone through this journey. So our research is an observational descriptive cross-sectional study, and we conducted among 396 participants from 5 non-medical faculties, including Faculty of Arts, Faculty of Agriculture, Faculty of Engineering, Faculty of Management, and Faculty of Science. Our study was conducted from July to August 2023. And we recruited these participants using non-probability consecutive sampling method. And we obtained their informed written consent. We used a self-administered printed version of a questionnaire as a data collection tool. And we obtained the ethical approval from our ethical review committee in the faculty process. And after collecting the data, we used the analytical software as the journal. So we let the participants to exercise their autonomy by letting anonymity. So after analyzing the data, we displayed thyroid disorder, while only 40 students had the exposure status. Out of them, 15 were diagnosed thyroid patients, while 25 had a family member who was diagnosed with the thyroid disease. So, this graph shows the knowledge on symptoms regarding to the low thyroid hormone levels. So, according to this bar graph, you can see the majority has identified that a swelling of the neck has been the commonest presentation with hypothyroidism, which is followed by the neck pain and the lethargy. The symptoms regarding to the hyperthyroidism seem to be similar, and it also looks similar in symptoms related to the thyroid cancers. So according to these results, that majority has identified if there is a swelling in the thyroid gland, if there is a swelling in the neck, that there should be something wrong with thyroid. So as the comparison of the knowledge in between variables, we have identified that being a female has associated with acquiring a good knowledge regarding to knowledge on common thyroid disorders. And also having followed by the biology stream in the advanced level curriculum has been also shown associated with the good knowledge regarding common thyroid disorders. And the next thing is having a previous exposure status to the thyroid disorders also have been shown associated with the good knowledge regarding common thyroid disorders. So ultimately, our study concluded that being a female, having followed by the biology stream in advanced level curriculum, and having a previous thyroid exposure disease status either by themselves or by their family members has been positively impacted to gaining a better knowledge regarding the common thyroid disorders. So now let's move on what our research recommends. So we recommend to introduce a concise chapter not only in the A-level biology stream but also in the ordinary level curriculum on endocrine abnormalities with a special focus towards thyroid disorders. And awareness programs conducted by the Ministry of the Health on thyroid disorders should be streamlined towards educating the general population, and it should be given due importance just like any other endocrine abnormalities like diabetic mellitus. And also we recommend to conduct future researches to identify more effective ways of improving the knowledge on common thyroid disorders. So these are our references, and I'll take this opportunity to give our gratitude towards our research supervisor, Dr. Nakshita Patlana, to guiding us during this process. Thank you.
Thank you very much, and a good presentation and good work. Now the sample again, not about this thing. Within 2 weeks, always went beyond 2 weeks for the data collection from 396 patients.
Then 5 members in the group.
So you divided that. Okay. What was the kind of questionnaire format now? Is it an interview administered questionnaire?
Yes, sir. We use the printed questionnaire. First we take the English version and then translate it to simple and Tamil versions.
You yourself did that too?
No.
You used a translator? Okay. Did you validate that questionnaire? Did you validate the questionnaire?
No, that was a limitation.
Okay. Okay. I don't have much questions. Bit of a little comment that when it comes to scientific presentation, we generally don't do these flashing things, bumping things, right? You know, just avoid that. I mean, simple advice. Okay. Good work. Thank you.
Is it, whose idea is this?
So the entire group decided to carry on this.
Okay. So what is the clinical implication of by doing this? You mentioned some. Anything else you want to tell?
Yes, sir. After deciding to do some research on thyroid disorders, we went through the literature review, but we couldn't find much researchers done in Sri Lanka. But some had done with the clinical setup, but there were no studies conducted among the university students. And we think as the future workforce, we should be empowered with the knowledge.
Yeah, community assessment. Thank you.
Thank you.
Our final presenter for this session is Mr. K.H.K.G. Karyavasam, who will be delivering their presentation on a study on the applicability of the modified APLS weight for age calculation formula on a selected population of Sri Lankan children attending a tertiary care hospital.
Good afternoon, ladies and gentlemen. I'm here today on behalf of research group 19, to deliver the oral presentation of our research, the applicability of the modified APLS weight for age calculation formula on a selected population of Sri Lankan children attending a tertiary care hospital. So the advanced pediatric life support formula, otherwise known as the APLS formula, was a formula developed in the UK in the early to mid 1950s, and as you all know, in many therapeutic interventions such as drug dose calculations and fluid dose calculations, we need the patient's weight. It is true especially in pediatric practice. So in pediatric emergencies where the measurement of weight is not always feasible, is where this formula comes into play. So as you can see, the current version of the formula, known as the modified APLS formula, has three components for three separate age groups. So in our literature review, we actually found that the performance of the formula is heavily dependent on the population they have conducted the study in. So it is actually due to the weight of a normal healthy child is being affected by national, regional, socio-economic, and genetic and ethnic factors. So on top of that, we did not find any Sri Lankan studies regarding the matter, and the closest one that we found was an Indian study, which actually in which the APLS formula have actually overestimated the weight of their children. So our aim was to determine whether the modified APLS formula is compatible to be used with Sri Lankan children attending a tertiary care hospital. We actually measured the applicability of the formula in the age range which it was designed for, which was 12 years to 1 month, and we measured the applicability of the three components of the modified APLS formula separately, and in the end we measured any possible significant differences in the results of applying the modified APLS formula in the two sexes separately. So this was a retrospective cross-sectional study, as we used recorded data from BHTs and the hospital database, and our sample size was to be 385 in total, and at least 100 participants in each age category according to the brand suggestion. Here you can see we measured the effects of age and gender on the performance of the formula. Unfortunately, we could not measure the effects of ethnicity and nutritional state, as it would increase our study sample to an amount which is not feasible with the time we had available for the research. And any conditions which would affect the normal weight of a child, like chronic diseases, genetic syndromes, were excluded from the study because they would produce a bias. And data were entered into the spreadsheet, stratified into the three age categories, and the estimation errors, which is the difference between the weight estimation and the measured weight, were then calculated. And the percentages of estimated weights within 10%, 20%, and more than 20% of the measured weights were then calculated, and the normality of the distributions within the sample were checked, and the estimated errors were analyzed using both descriptive and non-parametric inferential statistical tools because we had a non-normal distribution within our sample. And we did that for the whole sample and the 3 age categories separately and the 2 sexes separately as well. Finally, the agreement between the estimated and measured weights was also graphically displayed using a Bland-Altman plot. So a total of 387 children met the inclusion criteria of our study, and the demographics are shown below. We actually had slightly more number of male students, male participants, and participants in the 1 to 5 years category were relatively more. The sample as a whole had a mean estimation error of 3.161 kg with a mean percentage of error of 26.9%. The PW10, PW20 and PW more than 20 values which I described earlier were 23.3, 43.9 and 56.1 respectively. And the interesting thing was that all these values showed an increasing trend with age in a sample. So for inferentials, we did a Wilcoxon sign rank test to see if there's any significant difference between the measured weight and estimated weight within the 3 categories. And a man-Whitney U test was aimed to find any significant difference between the 2 sexes produced 2 sexes. And Spearman rank correlation the Spearman rank correlation showed a significant positive correlation between the estimated and measured weights in our studies, which was the only only surprising finding. All the other findings pointed to the measured and estimated weights having a significant difference in between them. So finally, the Bland-Altman analysis for estimated and measured weights produced a bias of 3.21 kg, and the Bland-Altman's bias increased, and the range of 95% limits of agreement widened with the increase in age, preserving the previously observed trend. So the modified APLS formula overestimated the weights of our study sample, with a degree of overestimation increasing with age. So for the PW10, PW20 values, there were many criteria defining the clinically safe margin. So the most reasonable criteria we found was PW20 more than 69% to be clinically safe. So none of only the 1 to 11 month age category produced a PW20 more than 69, even though it having a PW10 value which was not satisfactory. So inferential statistics showed that there is a statistically significant difference between the measured and estimated weights across all age categories. No significant difference was found when estimating the weights of the 2 sexes separately in the sample. Finally, the Bland-Altman analysis further reinforced our findings with the formula showing both poor accuracy, precision, with the agreement being less as the age increased. So our results were in concordance with the results of the studies performed with similar populations. So we actually found an Indian study and another study conducted in the Philippines with similar results, and many African studies with samples with similar backgrounds producing similar results. However, in the Western world, where the developed countries, the economy is better, we found the formula to produce an underestimation or produce a good overall accuracy. So with the developing countries such as ours having a higher prevalence of malnourishment in contrast to the other developed countries having a higher prevalence of childhood obesity, this demonstrates the significant effect of the background, national, regional, socio-economic, genetic and ethnic factors of on the performance of the formula. So in conclusion, the overall performance of the modified APLS formula was very poor in our population, having both poor accuracy and precision. The formula cannot be recommended to be used as it cannot be deemed clinically safe in Sri Lankan children. And our recommendations are to perform similar studies using larger samples, so the results will be more generalizable, and to derive a simple to use age-based weight estimation formula for our own population in the study. So these were our references for research, and I would also like to take this opportunity to thank our research supervisor, Professor Pathum Disanayake, and we also extend our gratitude to Dr. K.M.G.K. Bandara, the Director of Teaching Hospital PERADENIYA, for granting us permission to collect patients' data. And we are grateful for the ward sister and the nursing staff of the pediatric ward of Teaching Hospital PERADENIYA, who measured the weights and documented them in the BHTs. We also thank you for Mrs. Ridma P. Karunatilaka from the Department of Microbiology for helping us with the statistical analysis. Thank you.
How accurate, because this is a retrospective study, the data you have collected, you check with their own records and accuracy of the data?
We actually met the staff and discussed it with them as well. And we calibrated all the scales before starting our study. And we checked for the calibration in the end as well.
So you said it's retrospective study?
Yes, so the data collected were retrospective from the BHTs.
Okay.
But those weights were measured by the nursing staff and were recorded in the BHTs. We asked the staff to calibrate the scales before and after to see if there's any possible error. We collected the data from the BHTs retrospectively even after the patients were discharged. We, before sending the BHTs to the record room, we kept them and collected the data.
Then whose idea is this one?
So we actually had a few research topics at first. Then we all got together, our research group and our supervisor, and we discussed. This particular idea was one of our supervisors. And in the end, we decided to go ahead with this particular topic because our supervisor is a professor from the pediatric department, and he has expertise in this field. So it would be easy for us as well. So
what is the clinical implications by doing this research? Actually, you have mentioned it. Anything else you want to explain?
So we actually did not find any studies on these errors of weight estimation causing problems, but as this produces an overestimation of weight, it can lead to drug toxicities and all the therapeutic interventions being more than what is supposed to be for the child. And it could have.
Will you find any cases among these patients?
We did not find any cases. And they have no studies as well, so. Thank you.
Thank you. We kindly request the speaker to please remain on stage to receive the certificate from our judges. We cordially invite Dr. Manjula Herath to award the certificate. Thank you very much.
Now, we cordially invite Dr. Kirti Disanayaka to present the rest of the certificates. We kindly request the remaining presenters to join us on stage in speaker order to receive their certificates. The speakers, please join us on stage. Thank you very much.
We would like to extend our gratitude to our chairperson and judge for overseeing an excellent session.
Thus, we cordially invite Dr. S. Krishna Pradeep from the Department of Pediatrics to come up on stage along with our session's chairperson and judge to award the certificates. And that concludes the first parallel session of oral presentations.